Hello and welcome. You're watching The Mojo Story. I'm Barkha Dutt. This is our independent digital platform that does an in-depth analysis of the big stories of the day. On the program today, we'll be looking at India's vaccination drive with two of the country's foremost experts on the subject. But first, let's take a look at where the numbers stand as of right now. We have 3.7 crore vaccine doses that have been administered, and more than this number has actually been sent to other countries abroad, which is under the Vaccine by 3 program. They have either been exported or gifted. So if you take a look at the next slide, which will come up shortly, 20 lakh doses have been given just since yesterday in the last 24 hours, but the number needs to be much higher. And as we've been saying, more than 50 million doses, in fact, 59 million vaccines have been sent abroad globally. Now, are we proceeding at the pace at which we should be? Let us introduce our experts on the panel at the moment. We're joined by Kiran, the chairperson of Biocon, and we're joined by Professor Sudhir, who's of course with us as well, and we'll get both of them in one by one. And I'd like to start with you before I come to Sudhir. Krishna, I'd like to start with you, Kiran, if I may. You had a very interesting tweet this morning, which spoke about how science and not logic needs to be driving India's vaccination program. And you were talking about a kind of archaic logic. And when we look at the numbers do tell their own story, Kiran. So go ahead and explain what you mean. Here's what we know. We know that 37 million Indians have been vaccinated, and we know that close to 59 million vaccines have actually been sent abroad. So effectively, while we're doing well, we're not doing as well as we should. We hit a record of 30 lakhs on one day on Monday, but that number has dipped to 20 lakh. And this is at a time when we're seeing a fresh surge in cases. So go ahead.
So Barkha, thanks for inviting me to this show. My tweet was really about the fact that if you think about logic, it's undebatable, trying to go through a sequential, stratified, staggered vaccination program that starts with healthcare workers, essential workers, over 60 years of age, people with comorbidities over 45, and so on and so forth. Because that really talks about protecting the most vulnerable people in our population. Fine. But what are we grappling with right now? We are grappling with very high levels of transmission. So what we are doing is logically very sound for protection of vulnerable populations, but is it addressing transmission? And the answer in my mind is no. Because if you use that logic, first and foremost, you can see that we are only using half the vaccines which have been deployed, which means that our vaccination rates are also very, very low. It's in fact half the rate at which it should be, which means that our vaccine deployment is also not at a pace and scale that it should be. So we do have many challenges to address. Now, if you were to use scientific rationale as to how do we deal with the spread of this pandemic, as you know, we are in a relatively safe space when it comes to vaccination. Even today, even though we are seeing a surge in numbers, we are still pretty safe when it comes to the mortality rates. But if you don't want things to go out of control, I think we have to increase the pace and scale of vaccination. But more importantly, we need to start vaccinating those who are transmitting the disease very rapidly, because that's what we are challenged with today. It's not the elderly that is spreading the disease, it is the young that is spreading the disease. And as you know, even today, there's a lot of data to show that this huge spread that you're seeing today is actually in a young population below the age of 39. So I think we need to be very, very quick and agile about responding to this challenge. And to me, the way we can respond to this challenge is through a scientific rationale. What do I mean by that?
Yeah.
Let's start let's start surgically targeting the populations that are showing the surge. What is the surge due to? Is it because of dense clusters and congregation of people? Is it because we are seeing new variants in certain populations? Is it because there are certain classes of people who are naturally exposed? What are the reasons? Those are the kind of populations that we should prioritize. And according to me, we have enough scientific methodologies and algorithms with which to surgically target these kind of populations that are big spreaders and
Okay. Okay. Now, before we come to the specifics of the algorithms and how tech can be used, and I know Professor Sudhir Krishna will want to come in on that also, Kiran. If you look at the cases, the Prime Minister told the Chief Ministers that we must at all costs avoid the next wave, that we are at the precipice of a next wave. But if you break it down further, you have 6 states that are actually contributing to these cases. Maharashtra, Kerala, Punjab, Karnataka, and Tamil Nadu are the top 5. So actually, it's not as if all of India is reeling under the potential of a new surge. It is very identified. And in these states, Maharashtra, for example, is the worst off. Now, when we talk about whether the vaccination program needs to be universalized, which means anyone above 18 should be allowed to get a vaccine, you would perhaps look at it somewhat differently, and you would say you can do targeted vaccinations both in clusters and in age groups. So pick up the data and tell us how you would design the vaccine rollout at this point.
So, logic will tell you that, look, let's look at Maharashtra, all these states that you talked about, they should be prioritized in terms of our vaccination program. But in addition to that, you need to use a scientific rationale to say, let's further break down that data to see where is these numbers coming from. Is it from very dense clusters? Like, is it all coming from Mumbai? And if so, where are they coming from? Is it from sort of densely packed suburbs? Is it coming from, residential buildings? Is it coming from where? Where is it coming from? I think that's the way you then go about really, vaccinating those populations. Is what I'm trying to say.
So you are against at this moment universalizing for the country. You are saying let's target clusters, and the worst clusters, everyone should be allowed to get the vaccine above 18. Kiran, am I right?
No, I'm actually advocating for universalizing the vaccine, because that's a smart thing to do. Because when you're in a safe zone, you want to make sure that you don't get into this kind of a situation. So if you actually are seeing numbers come down, it's better to start parallelly universalizing the vaccine from the phase 2 and phase 3 parallelly. So what I'm saying is open it up. Because as it is, you're not vaccinating more than half the eligible population for whatever reason. There's vaccine hesitancy, there's vaccine skepticism, there's all these concerns around, those recent controversies created by the European countries and so on and so forth. So I just think you need to vaccinate everyone ASAP just to be on the safe side. But if you have to, balance the supplies, then I would prioritize these large surge, these populations that are showing these large surges. Yeah. But my advocacy is for universalizing the vaccine. And more importantly, I also believe that you should also allow walk-in vaccinations at large scale, because I think all our private sector hospitals are in a position to vaccinate people at scale. I mean, I myself have seen a number of hospitals. They are handling it in a very systematic way. They're able to vaccinate large numbers every day, and I think that's what we should be really embarking.
Okay, lots to unpack there. Walk-in vaccinations, universalize it. If there is a demand-supply mismatch, then look at the clusters. Look at the 6 states that are accounting for more than actually 75% of the surge in the last couple of days, is what the data tells you. Sudhir, if you want to come in there, right? So the government would argue that we're not doing too badly. In fact, we are now number 2, right after the United States in the speed of rollout. But it's wavering from day to day. So if Monday hit 30 lakhs per day, you saw the last 24 hours already fall down to 20 lakhs. Now that's not a good sign. The numbers should only be going up from here, Sudhir.
It's not a question of you're doing badly or worse. If you look at if you Google the Ebola ring vaccination strategy on the CDC site, there's actually a very useful model out there. So Ebola was probably one of the most recent examples of ring vaccination. And I think what Kiran is saying is that in addition to universalizing be strategic, and we've got capacity, we've got modelers, so the Ebola ring vaccination, there was a whole team of people, from modelers to people in the community to the vaccine developers. So in hotspots, and you've actually identified by numbers in your hotspots, you should be thinking about targeted ring vaccination strategies. And I think there are models out there. Those models will give you learning curves. The UK and the US are far more homogeneous populations. You can actually roll out cold chain vaccines very easily. So I don't think those models should be directly applied here. The broad conceptualization of vaccines is fine, but you should fine tune it. You should, learn from it. One of the other challenges is that we've been very data poor in recent times. The Covaxin study has looked at, has generated interim third phase data on efficacy, transmission, and so on. But we've generated very little efficacy data, very little transmission data with the huge Covishield vaccination. So we should really get on with generating the data, learning from that, and then applying it across the place. I mean, we've done okay so far. You've had a pandemic where your sort of death rates per million are about 114 per million compared to the UK, which is 1,800. Kiran is absolutely right. The fatality rates for 35,000 infections, if you look at the rise in the early initial phase of the infection, it was huge compared to probably four less. So this is not the time to be complacent. And I think what Kiran is saying is, this is the time to be smart. I mean, I don't think she's attacking the system. What she's saying is, be focused, be targeted, learn, be proactive. I'm sort of putting words in Kiran's mouth, but I'm sure she'd agree with all of that.
No. I wasn't suggesting she's targeting the system, but I'm just saying that there are two dimensions to this. There are people, even including doctors, who are hesitant to get the vaccine. So vaccines are actually being wasted. We've seen, for example, in the month of February, 43% of health workers, according to India Spend, did not show up for their second dose. I'm talking about health workers, Sudhir. In states like Telangana, media reports now suggest that 17% vaccines got wasted. So on one hand, you have people who are not showing up for the vaccine. On the other hand, you have people who are very eager to get the vaccine, but it hasn't been opened up. And I think that's what Kiran is saying. Open it up.
I have no challenge with what Kiran is saying at all. All I'm saying is that the vaccine hesitancy issue should be driven by data. There's only so much that communication and sort of persuasion can drive. I mean, there is something called data, and we're just not investing enough in data right now. We should get on with it, and we should have models for look. I think it's very important to explain to the public that vaccination is a public health issue. Of course, individuals are vaccinated for their protection, but you have to vaccinate at the level of augmenting herd immunity in a targeted manner. And it's not just augmenting herd immunity. It's not just vaccinating on scale and hoping that herd immunity will kick in. You must apply. I mean, I don't know the word that Kiran used, logic or science. I mean, that's not the issue. We're both saying the same thing, that there must be targeted efforts, learn from it, and then, you can apply it again later. By chance, if you get variants in local areas coming up tomorrow, and you already have a sort of ring vaccination strategy in place, then go ahead and use it. And we can actually discuss what those strategies are.
Yeah, I will come to the strategy of how to respond to variants in a moment. But I just want to stay focused on the algorithms and the data and how vaccines should either be universalized or better targeted, right, Kiran? And I think that's the point. Either universalize it or target it in clusters in these 6 states if you have to. Yeah.
Sudhir actually brought up a very important point. We all talk about herd immunity, but herd immunity in such a large population is very, very tough to achieve in the way we think, okay? So I think this targeted vaccine-induced herd immunity is much easier to build rather than at a large population scale over a large period of time. And I think that's what also Sudhir is referring to, saying that we should have this targeted modeling where we actually start looking at populations that are actually going to help us, prevent transmission, slow down any kind of spread. We need to think more scientifically than just applying a general logic.
So when you say think scientifically, one of the things, Kiran, that you have been saying is that the assumption that older people, like for example, let's talk about old age homes. I know that, you've been pointing out that if you're going to inoculate older people, but not their caregivers, if you're not going to look at a younger population, the working population, right? Then it kind of defeats the purpose, because actually the people going out, the people at the front line, so to speak, who have the exposure and then who are carrying that exposure back home aren't getting vaccinated. So talk a little bit about that.
No, my view is, we don't live in old people's homes. Okay, our elderly live at home with younger people, in joint families. So when you are just going to vaccinate the older people, and that too, you need two vaccinations to actually be protected. Today, you're already hearing so many stories of people who are being infected after the first vaccine, or even within a week of the second vaccine. It takes time. So we must understand how the vaccine works. A lot of the people, not young, even the people over 60 who are vaccinating themselves, or people over the age of 45 with comorbidities who are vaccinating themselves, they believe that once they vaccinate themselves, they're fine. But they're not, because they should realize that they first it takes time for that vaccine to kick in terms of immune protection, and then they need the second shot to really protect them, and that too, it happens many weeks later. So I think we must understand that the elderly who might receive one shot of vaccines are absolutely not protected if they're living in joint families with younger people. That's what I meant by saying that it doesn't make sense just to protect the elderly, one old person or two old people living in a family, and the rest of them are merrily going out, getting sort of getting the virus, coming back, and then passing it on to everyone. That's what I mean by saying let's be scientifically, sensible, and not just using this broad logic that let's protect the elderly.
Yeah.
And you need
so specifically, why do you think the government, I know there was a proposal discussed at the Prime Minister and Chief Minister's meeting to universalize the vaccine, but the government hasn't given its go-ahead yet to this. Where do you think the hesitation is? Do you think we're producing fast enough to universalize the vaccines? First, that would be the question.
That is the concern, that maybe our current capacity may not be able to match the kind of demand we might create when you universalize the vaccine. I think that is the real concern. But according to me, I think we just need to start. That's why I said prioritize vaccination in terms of the spread of the virus and the surges, because in the next few months you will have enough vaccine adequacy to universalize it very, very rapidly. Today, you may not be in that position to completely universalize the vaccine because we don't have enough capacity. Right now, we just have two vaccines approved, and between them, I think they're producing about 60 million doses per month. That's not enough. We need to quadruple that kind of capacity. And that quadrupling of the capacity will come with 2 or 3 other vaccines also coming into the market. The Sputnik vaccine is supposed to come into the market. The Novavax is supposed to come, and J&J also might follow. So when you have all these vaccines coming in, and then more plants producing these vaccines, you're going to increase your capacity. That's when you can safely...
But does that mean that at 60 million doses a month, we cannot universalize right now? Could we, for example, universalize in the 6 states worst hit by the vaccine? Could that be a start? By the virus.
I would rather say that you can, maybe even to prioritize those populations might be a good idea, just the way, Sudhir spoke about, the modeling that goes on into making sure that you target the virus and the spread and contain it. All those modeling data is there, but let's start looking at that rather than just blindly going by this stratified approach that we've created, which is not only slow, but suboptimal when it comes to transmission.
I think it's a very good point. And
the way we've gone about it is we are focusing on protecting a certain part of our population, but we are not at all now focusing on preventing transmission. And that's why you need to have all this data. And Sudhir is absolutely right. We've now got, almost 40 million people dosed with the vaccine. Where is the transmission data? Are you collecting that data? Are you seeing what's happening? We don't have all of that.
So let me ask Sudhir two questions. One, Sudhir, you're looking at the slide of how many cases have been reported in the last 24 hours, which are a little over 35,000. The case fatality rate, the CFR continues to be below 1.5%. But obviously, the surge is something that's worrying, and that's where transmission will come in. But the vaccine is not supposed to be 100% guarantee against the transmission, not till herd immunity is reached. The vaccine is meant to prevent hospitalization and mortality. So my first question would be, should the data focus on the CFR, the deaths, the case fatality, instead of the cases testing positive? Are we getting too paranoid about how many people are testing positive? Question one. Question two, given that we know that there are the top 6 states, and in that we know that Maharashtra is leaps and bounds more vulnerable than any other state. How should the vaccine rollout be targeted using data, according to you, creating algorithms like you and Kiran have been talking about?
So actually, I think Kiran has already said that prioritization is not against universalization. Even if you had infinite capacity at this moment, there is no way that you can, immunize everybody in one shot. You'd have logistics issues, you'd have vaccine hesitancy issues, you'd have all those issues. So that's an unreasonable expectation that even if you had infinite capacity, can I immunize everybody tomorrow? It's not doable, right? So given that, and given the fact that you know where your clusters are in terms of infection, it makes a lot of sense to prioritize within the context of an overall immunization strategy. And I think that's what both Kiran and I are saying, that, be data driven by what you have. Now, remember that the vaccines that you have, you're correct, absolutely, were not the sort of AstraZeneca vaccine in the trials in the US have actually not shown great protection against transmission dynamics. They were good at protecting sort of progression to severe disease. So start looking at mechanisms now where you can add on to your containment strategies by vaccination. So for example, probably the Covaxin vaccine, because of the fact that it's got multiple units, of the viruses. And remember that the way the immune system actually works is that if you have multiple units of the viruses, T cell recognition actually occurs at the level of genetic diversity, to some extent, even the antibody recognition. So you'd have a huge amplifier effect. So start looking at, what the efficacy and transmission dynamics is with the vaccines that you have in hand, and, maybe supplement in areas where that you need to with targeted vaccines. And you will probably learn a lot and achieve some goals. Kiran and I have actually both talked about innovations in vaccine strategy. I'll leave it for her to position it, and then I can come in again.
And in fact, there's a question on that, Kiran, saying that countries never quite achieve herd immunity because as they move in that direction, new variants, mutations of the virus actually pop out. So how do you tackle that? And I know the two of you have been doing some sort of research on this, so go ahead and take that question.
So, if you look at all the vaccines that have been developed, in the world, there are many very similar platforms. So, for instance, the adenoviral vector vaccines are all based on spike protein, but DNA based. Okay, so basically, you're changing the DNA of the virus, and you're basically couching it in the adenovirus and telling the body to make a spike protein, and then that's the immune response you get. mRNA vaccines have just taken the shortcut. They said, forget about a viral vector, we'll just give the body a shot of mRNA and the same spike protein can be produced and you'll get an immune response. But they're all only focusing on a spike protein that was actually developed based on the first virus, okay? Now, that there are variants, and these variants are actually all appearing in the spike protein region. So you're seeing that some are more, infectious than others. So you're seeing that already in many of these variants, like the South African variant and the UK variant.
Yeah.
Now, what Sudhir was saying was that if you look at an inactivated virus, which is what the Covaxin vaccine is, you actually have the whole virus intact, and you've just basically inactivated it or killed it and feeding that entire virus to the to patients. I mean, to people. So they actually launch a very different immune response than a spike protein response. So it could be a larger response. Now, this is not to take away and say one is better than the other. But if you combine them, you get a synergistic effect that could actually be quite interesting. So these are the kind of answers you need, saying, why don't we do some trials to see whether a combination of the vaccine gives you better protection and actually takes on the variants much better? Now, those are the questions we have to ask. We don't know the answers, but we need to do those trials.
So
Second,
you're actually saying that we should we should in India be looking at a trial that mixes the Covaxin and the Covishield, because that allows you a better response to mutations and variants of the virus.
Yes, and actually a mix and match strategy of vaccines is always quite interesting, especially since you know that adenoviral vector vaccines, they start basically diminishing the immune response if you take them over and over again, because this is a virus that your body is very used to. So the first few times it might get fooled, but after that it kind of doesn't even respond to it. So by mixing another type of a viral vector vaccine also helps. So you should try and do mix and match. If you remember, even in the UK, they were trying to mix and match the Pfizer vaccine with the AstraZeneca vaccine. That also is an interesting experiment to see that can you actually elicit a very different immune response by doing that. So you don't want your body to get too used to a certain type of a vaccine. And especially if you have to keep doing this annually, which is what it is showing, because right now we don't know the durability of response, then you better have a strategy that protects you in a much better way.
So, do you want to add to that? The UK did initially talk about a mix and match sort of approach. I don't know. Friends in London seem to be though getting only one or the other of the vaccine. So, Kiran, I don't know if they kind of just thought they'd do that and then didn't do it.
About it. They just talked about it, but they didn't really do very much.
But the science behind it, Sudhir, if you want to just explain it simply to people who are not medical people, just explain it simply.
Let me just take you through what Kiran said in a sort of a little bit more scientific term. You have the spike protein, immunization, which you do with the adenovirus in the first round, right? If you, for example, did a booster with the Covaxin, you would be still amplifying the spike protein. But you would not be amplifying the response to the backbone, which is the adenovirus, right? Because you're not immunizing twice with the adenovirus. So that's a positive. The other positive that you'd have is, I suspect that the transmission dynamics is actually blocked by the large number of virus proteins of Covaxin. Remember that there are three components in your viral infection. There's the transmission, there's replication, and there's progression. And I think the spike protein actually does pretty well, both in terms of generating CTLs and other responses to progression. And for severe disease progression, we've seen that blocked quite well. I suspect that when it comes to transmission and the initial replication, you probably need to take a relook at that, particularly transmission. And Kiran has talked about that quite a bit in terms of using other proteins. So you, I think, have intellectually a fairly sound strategy. Remember that you're not actually looking at seropositivity or seronegativity before you immunize. So vaccines are not drugs. You can actually boost responses selectively by being creative, by being clever about this whole thing. So I think there's a huge opportunity. It's important to do this in a manner which is structured both scientifically and in terms of communication, because there's otherwise, you don't want to add now to the vaccine hesitancy and give people a sense that people don't know what they're doing, so they're throwing in mixes and matches. That's not the case at all. As vaccinations evolve, as epidemics evolve, you learn from what you have, you use the tools that you have, you recombine.
So should there be a trial for mixing and matching these vaccines? And what would be the trial group? Would it be people obviously who've not got either of the vaccines, Kiran? I mean, I'm breaking this down into brass tacks. Yeah.
No, actually, you can do a lot of very interesting trials. I think ICMR should be doing these kind of trials. In fact, another big benefit out of a mix and match strategy is that, depending on the availability of any vaccine at any center, you can very safely take any vaccine at any time and then follow it up with a booster dose with any other vaccine. And that's the kind of thing we should be looking at, because immunologically and scientifically, that is very doable. And I think Sudhir said that very well. He said that, look, immunology and vaccines are very different to drugs. Drugs are very, very, very specific and targeted. Here we are trying to elicit an immune response in a very different way. So we should try and see if there are approved vaccines, can you basically mix and match them?
But how long would this process take? Because time is also of the essence here, Kiran. Like what we really need to do, as you said, is to open up a vaccine program, right?
I will not even suggest. See, the point is that you are not really, you're keeping people safe, right? We know that scientifically it should work. Okay. The point is, okay, just study those people. You're going to vaccinate people. You don't need more than a few thousand to know what is the, after all, what are you going to, measure? You're going to respond, you're going to measure the immune response, right? So the immunogenicity or the immune response, then you're going to also try and check on efficacy. Now, efficacy, of course, becomes a big problem if you don't have a large enough population. But I think right now, making judgment calls on saying that, okay, if this is the immune response, if this is the T cell response, the antibody response, the likelihood of it having the same efficacy or better efficacy than X, Y, or Z ought to be very easy to extrapolate.
Sudhir, there has also been a controversy, and a needless controversy, according to me, but that will strengthen the hands of anti-vaxxers on AstraZeneca and blood clotting. And even The Guardian had a very clear report on this, saying that there are only 30 reported cases of clotting after 5 million doses of this vaccine were given. And none of them were, by the way, the Covishield that's produced in India. I just want to make that clear. But it's going to lead to people saying, oh, maybe the vaccine is not safe, and so on. And we've had virologists saying this is a bluff. This is absolutely not true. We have a record of 71 deaths in India after 37 million people vaccinated, and there's nothing to link the two, which means that there could have been fatalities from other reasons. How do we address this sort of rumor mongering around blood clotting, DVT, and so on that's now entered the ether?
So there are two issues here. One is the policy response, and the other is the communication about rumor mongering. In terms of policy response, on Saturday on another TV channel, I think it was the Mirror on the 7 o'clock news, I said very clearly that the ICMR response, which was to collect more data and not take hasty decisions, is correct. I don't think the evidence right now from what we've seen in India and from what we've seen abroad mandates a sort of dramatic intervention. I think even Kiran would agree with that we should be data driven. In terms of the rumor mongering, I think there is only one solution to this, and that is to actually show that we are succeeding. And we need to succeed and show very clearly that our interventions are working. So I'd go back to the point that I started early on. The public is not stupid. The public understands the data. The public understands success. The public understands failure. And I think we should just get on with documenting what's working and try and reduce what's not working. And also be very honest that there's a learning curve in this whole thing. I mean, what is the problem?
So let me ask both of you, what is working and what is not working so far? I think that's important to address, right? I'll start with you, Sudhir, and the same question to Kiran. What is working and what should be done better?
I think deployment is working. We have 2 vaccines which are working. They've passed through the first phase. We must massively increase the amount of data that we are learning from these trials. So we, at this moment, don't know what is working very well in terms of refining this process. And we must refine the process. We must educate the public that, a mix and match approach is just an evolution. And that, as pandemics evolve, as vaccine strategies evolve, systems have to evolve. There is nothing, you don't have the same response that you had last March or early this December. And you must be context specific. You must be both global and local. Everything that I'm saying is just common sense, and treat the public. The public is well informed. I mean, this idea that there are experts in public, I just don't buy that at all. I mean, I don't know what Kiran thinks about this, but I think the public is actually as well informed as anybody else and capable of rational decisions.
Kiran, what's working and what's not?
Well, I think, what's working is definitely that we've got all our public and private sector medical centers set up, and they're all deploying vaccines very efficiently, I would say. I think what is not working is this very stratified, structured way of vaccine deployment, which is slowing down the pace of vaccination, according to me. Even today, if we actually free up the system, you'll be able to vaccinate 5 million people a day with ease. That is the way I look at it.
Define freeing up the system. What do you mean by freeing up the system? 5 million is 50 lakhs. The highest number we've reached is 30 lakhs this week.
But for a country like ours with so many medical centers, there's no reason why we shouldn't be able to do it. For the simple reason that, of course, we've got the capability to deliver on it. We've got the vaccines to do that. Today, what is actually slowing it down is all this procedures that we have of first fixing an appointment, registering yourself, all that is also slowing down the vaccination process, by the way, because half the time the COVID app does not seems to have glitches. The other time, half the time, people don't know how to register. So I personally believe that what's really working well is for people to really just walk up to these medical centers. I know that in our hospital, lots of people are just coming there. They're sort of waiting in a waiting area. People are coming and helping them to register, and they can come and take the vaccination on the spot. So these are all walk-in vaccinations. The other thing that I also wanted to mention, Barkha, is that there's a huge amount of wastage, which is criminal according to me. We should not be wasting vaccines. In every other part of the world, you know, anybody who wants a vaccine can come at the end of the day to say, look, do you have any vaccines that have been left over? I'm willing to take the vaccine. That's the way we should be actually opening it up to anybody. You know, at the end of the day, if there are any vaccines which are not used, instead of wasting it, you should just vaccinate whoever lands up there. And I know that this is already happening in the US, where every pharmacy basically has put a sign up saying, do come, and we will be announcing how many vaccine shots are left at the end of the day, and we'll ask for volunteers, and we'll just randomly give you those things without your having to be eligible for it.
So you're basically saying that if those who are allotted are not using it, let the walk-ins happen. Let the walk-ins happen, and walk-ins is the way ahead. But I will again come back in concluding remarks from both of you on whether our production capacity is commensurate. When you talk about 5 million a day, that is literally peaking the 60 million that are being produced between Covaxin and Covishield, right, Kiran?
Yeah, I mean, if you want to vaccinate, that's why I said we are not in sync with our capacity at the moment. If you're going to produce 60 million doses a month, then, and you are going to have the capacity to vaccinate 150 million, because 5 million a day is like 150 million, then you're less than half of that capacity, right? But the fact is that Serum Institute has already said they will come up to 100 million by May. Okay. And, you know, even Bharat Biotech has said that they will come up to about 50 million by May. And then you've got others coming into the fold, like the Sputnik vaccine, you know, the J&J vaccine. Novavax also is going to be produced at $1 billion per year. So once you get to that May, June kind of time frame, I think you'll have enough vaccines to safely go in for universalization.
Yeah. Quick last word. So the point is we can't afford at this point to wait till May or June if we are to avoid you know, another wave, even if it is in these 6 states. And we simply as an economy cannot afford another lockdown strategy. We just absolutely cannot. It would devastate many of these states. So to avoid having to wait till the summer, one thing that you'd ask for in terms of a policy change, Sudhir, and then Kiran gets the last word.
So Nature today actually has an article which is actually very well written on all the sort of innovative strategies that exist in the lower income countries. And it's actually quite gratifying that we had a significant part of that. All our good companies, you know, Serum Institute and Bharat Biotech and the range of other companies. So just get on with innovation, because the innovation will help you with stopping variants. The innovation will help you with deployment. Where I possibly marginally disagree with Kiran is I don't think we need to only scale what we have. I think there are limits to what we already have. We must diversify. And I've said this consistently, that your strength is in your diversity of vaccines. They will give you various kinds of options. So I think please do take a look at Nature today. They've listed all the innovations from lower middle income countries. We should get on with opening them up, run trials, get on with it.
Okay, Kiran, last word to you. One specific policy change that you would tell the Ministry of Health, you would tell Dr. Harshvardhan, that you would say to the Niti Aayog, what would it be?
Well, I think, you know, basically we need to focus on a better model of vaccine deployment for sure. I would certainly like them to start, you know, parallelly vaccinating phase 2 and phase 3 eligible parts of the population. And I would like them to look at these, you know, sort of targeted population-based vaccinations on a priority basis to stop the transmission. I would like them to start collecting a lot of the data and let's do a lot of data crunching to see whether we can actually glean more information from them. And of course, who would disagree with the fact that we need to really encourage all the Indian innovative companies? I know a number of startups who are developing different types of vaccines, and I think we must support all of that. Actually, what we now need to also do is to start really preparing for surveillance in a big way. We're not doing enough surveillance. So, whether it is picking up variants and genomically profiling them through sequencing, whether it is really picking up the next surge and seeing what those surges are due to, whether it is really about doing surveillance on other viruses, but we need to get into that surveillance game very, very fast. And
one thing I haven't asked both of you, sorry, surveillance, you want to just explain what surveillance is? Because people will hear surveillance and feel a bit nervous. Kiran, what is surveillance?
No, what we mean is viral surveillance. Okay.
Right.
So basically what we are saying is, please be very, very astute about tracking variants. So when people are infected, it's not just about an RT-PCR test, but it's also, trying to find out why is there such a surge of test positivity rates in this particular region.
For example, Maharashtra, no one knows why Maharashtra is 61% of the...
No, they've actually traced a new variant in Maharashtra. And is that new variant more infectious than the previous variant? This is what we mean by surveillance, being prepared. And so you need to be in a state of preparedness, and we need to find ways of preventing. So surveillance, prevention, and preparedness is really what we should be focusing on as a country. And each one of them requires a very different set of capabilities, different sets of investment, and different sets of skills and data analysis.
Very quickly, there have been suggestions from certain commentators saying that the vaccine has to be made mandatory. The people who are refusing to take the vaccine are being irresponsible. They're holding the country back. Do either of you support mandatory vaccines?
No, you can't. Vaccination has to be a choice, but you need to really focus on advocacy. Because I think vaccine advocacy is extremely important to overcome vaccine hesitancy. So I think that is an extremely important recommendation I would make to the government. They are trying it in a big way. And of course, leading from the Prime Minister himself, I think people have talked about, taking a vaccine. So I think advocacy is very, very strong, but we really need to make sure that we continue with this advocacy, especially in light of this recent controversy created by the AstraZeneca vaccine concerns. So I think we need to
are you at all concerned about that controversy, or do you think it's European Union politics playing out between the United Kingdom and other European nations?
Yeah, I personally believe politics is messing up scientific analysis, and I think the fact that you've had a few cases and the percentage is so minuscule. And that in the general population, you do have people who are prone to embolisms and blood clots. And then I think there's a famous Latin phrase which says, what is it? Post hoc ergo propter
Basically
hoc.
like an ex post facto kind of.
You're trying to, link an event with some, data which doesn't really, work.
Yeah. All right. This has been an absolutely fascinating conversation. If I were to summarize, I think what I've heard: one, data. You need the data. You can apply the data in a more intelligent way. You can use technology in a better way than it's being used. Two, universalize. You are vaccinating less than your production. You can hit 5 million a day. Three, if you can't universalize for all states, look at the states. There are 6 states that are contributing the bulk of the surge. Within that, at least look at the clusters. Don't go by old logic of older people needed. Yes, older people needed, but the people going out working, getting exposed, picking up possibly the virus and then taking it home needed just as much and just as urgently. And then finally, the mix and match strategy, possibly doing trials with Covaxin and Covishield. Mix can be done with a few thousand people as a possible counter to mutant strains. All very informative and interesting. Thank you, Kiran. So much. You wanted to add something?
One last point I wanted to make, Barkha. Recently, I think the Punjab government said that they were going to include another set of people as essential or frontline workers, right? They talked about teachers, they talked about judges, they talked about NGO workers and some other people. Now, I am saying if you can include all of them as essential, why are you saying that our working class are not essential? Don't you want to open up the economy? Don't you think our workers also are essential workers and frontline workers? I mean, I was told that, well, the municipal workers are more exposed. I said, I don't agree with that. Our workers, our working class, take public transport. They are much more exposed or as exposed as anyone else. So I think we
agree totally.
That also wrong.
I have to say I agree 100%, and we cannot lose sight of the fact that we all need to reclaim our lives as a country, as a nation, as an economy.
Students too follow under that category. We want them to, educate themselves. We want them to go to colleges. Why are they less essential or less frontline?
Great point, Kiran. I really do hope somebody is listening. We're going to try and amplify this message. Kiran Shaw, Professor Sudhir, Krishna, thank you so much. Pleasure having you on the Mojo Story. And thank you so much. I know our audience learned a lot. We'll have both of you back as we track the rollout of India's vaccine program. In the meantime, goodbye and thanks for watching.
Thank you.
It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalism.